This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1212, recorded on April 24, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Paris, France, Daniel Griffin.
Hello, everyone. Yes, Paris, France, not Paris, Texas.
No, you don't want to be in Paris. I saw the movie Paris, Texas years ago. Did you see it?
I did not see it. Am I missing something?
It's a very interesting movie, but the Paris, Texas is nothing, so don't go there. I'm sorry if anyone from Paris, Texas is listening. Now, you have on your tie, you have a black tie with tiny points.
Yes, it is. It's a difficult one to
Okay, C. diff.
Yeah, you got it. Yeah. We have one of our listeners having a bit of a C difficulty lately, so I thought that was a good. But let's jump right into it. So I'm here in Paris, and I did a walking tour the other day, and it was Americans in Paris, and Ben Franklin, Thomas Jefferson, Tom Paine. Kind of an interesting connection there to the late 1700s, early 1800s. But I'll start off with the Thomas Jefferson quotation: "If ignorance is bliss, why aren't more people happy?" I thought that was entertaining. But then the other is, and this is sad for, I was raised Catholic. I think you were raised Catholic also, Vincent.
It sure was.
And Pope Francis passed. He was actually really a special individual. I lit a candle for him myself, and I lit one for my mom on his behalf as well. But really, pets go to heaven, just a lot of kindness here. So a tremendous loss. So I thought I would, a quotation, because I think maybe people need to remember, their moral compass in these difficult times. And I'm going to go to Notre Dame tomorrow to pay respects as well. But here's a quotation from Pope Francis: "A person who thinks only about building walls, whenever they may be, and not building bridges is not Christian." So just to start with that. But all right, I am going to, this is like a correction, actually. So correction, an update, clarification from your fired friend at CDC. Yes, you can say that there's no more getting in trouble. Dear Daniel, thank you for reading my email on the 419 episode regarding the cruel treatment of CDC employees, as if we are criminals. I had a small correction for the record and an embellishment. Last week you said Emerging Infectious Diseases, EID, is the agency mouthpiece. Actually, EID is a peer-reviewed journal and scientifically independent of the agency. MMWR is the mouthpiece. It is not peer-reviewed and has to have everything published, approved by the agency leaders. EID has been defunded, and in the proposed RFK budget, along with another CDC peer-reviewed journal, MMWR will continue it, albeit requiring approvals. A hidden problem with defunding the EID is that the U.S. government will be cutting out yet another early warning source of global health security info. As both political parties can agree, no American is safe unless everyone is safe. Because EID doesn't charge authors to publish open access, there are no fee barriers to submit early data from novel outbreaks. For example, in April 2020, EID received a case report from a local health department in rural China, which had bypassed Beijing health authorities to report directly to us one of the earliest reports of pre-symptomatic SARS-CoV-2 transmission. As the editor, I could then involve relevant CDC peer reviewers, which helped inform the agency about the threat, planned defunding of EID journal, of PEPFAR activities in dozens of low-resource countries, firing technical lead expertise at CDC, along with epidemiologists like me, and shuttering diplomatic outposts, etc., all would serve to reduce USG's access, United States government's access to early information, which limits our ability to respond in a timely manner to save lives as pandemics arise.
We've talked for weeks about how bad things are, but it's going to get worse because these individuals don't know what they're doing. They are malignantly incompetent.
All right, bird flu.
I'm not going to stop criticizing, Daniel, because this is horrible what's going on, and you know that too.
No, and I think it's important, and I get feedback. People like to know that they're not alone. They feel like, what is going on? And we've gotten a lot of positive feedback about people appreciate the fact that we're calling this out and we're saying, no, this is unacceptable. You're not alone in feeling like this is a disaster. This is not make America great. We are stepping away from greatness in science and public health and so many things. And there's no reason to do that. So. All right, bird flu, the article, The American Public's Disengagement with Highly Pathogenic Avian Influenza, Considerations for Vaccination and Dietary Changes, was published in the American Journal of Public Health. This was from a U.S. respondents, I guess it's a survey where we learned that only about a quarter knew that bird flu can spread to people. And over half were unaware that pasteurized milk is safer than raw milk. I think you drink a glass of pasteurized milk there, Vincent?
No, it's just watered down.
Also, less than 1/5 of respondents understood that H5N1 had been detected in cattle. Nearly a third were unwilling to change their diet to reduce their risk of exposure to the virus, or take a vaccine if it were available, even if it was recommended by the CDC. And only 26% of participants knew that people can get H5N1.
This is a problem. This is why many people think measles is mild, right? There's no awareness of science.
Yeah, I mean, I feel bad. We're doing the best we can, but we've fallen down. We didn't just get here yesterday. So we'll keep doing what we can do. But yeah, I think we need to keep pointing out that, yes, bird flu, H5N1, is something that human beings can get. It can be highly pathogenic. And several cases where we've seen particular types of bird flu have resulted in really high mortality. And yes, we've seen cattle get this. We've seen transmission from cattle to people. So far, it's only been a benign type of H5N1. And yes, if there's a vaccine to a disease that can kill you, it's really frightening that people would not be willing to do that. So a lot of education to keep going there. And along those lines, the University of Cambridge-based Diocinvax and Singapore's ACM Biolabs have signed a deal to jointly develop a next-generation universal avian flu vaccine with the potential for a mucosal delivery. Now, this is mRNA technology. The mRNA vaccine would target all major clades of the H5 avian flu, or the bird flu, and would be scalable for rapid global distribution. And the whole idea here is this would be just a spray up your nose. So we'll see what happens with that. Now, we had this thing a few months back, 2 months back, where they shut down all those poultry markets in New York. Remember that? And
Yeah,
so everyone rushed to sell the infected birds before it became effective. This reminds me of one of the hospitals where they said, we've found that this particular treatment is not really effective, and we're gonna stop using this for treatment of COVID effective Monday morning. I was like, what do you mean effective Monday morning? Well, not now. We know right now. You just said it doesn't work.
We're going to use up our supply, right?
Yes, we've already purchased it, so please go ahead and use up the supplies of this useless but expensive medicine. So, all right. Bird flu continues to spread among live poultry markets after shutdown order. Bird flu cases continue to be detected in live poultry markets in the city 2 months after the state temporarily shut them down to contain the virus. Highly pathogenic avian influenza, which is deadly in birds and other animals, but not known to be transmissible among humans. That's critical. So far, we're not seeing human-to-human transmission, but it's been found in 15 live poultry markets operating across 4 of the 5 boroughs, 2 more in Westchester and Long Island, since the February 7th directive. All right, Mpox, this is a little exciting here. We have found an animal source of Mpox emerges, and it's a squirrel. So this is a nice news piece in the journal Nature. But currently, this discovery is available in a preprint The preprint is entitled Fire-Footed Rope Squirrels, we get the Latin name there, are a reservoir host of monkeypox virus, the orthopoxvirus monkeypox. These investigators started with an outbreak of the Mpox virus in a group of wild sooty mangabes in Thai National Park, Côte d'Ivoire. How do I pronounce that? Do you know, Vincent?
Côte d'Ivoire.
Awesome. I mean, I'm the one in France, right?
Yeah, you are.
To track its origin, they analyzed rodents and wildlife carcasses from the region. They identified an infected fire-footed rope squirrel, found dead 3 kilometers from the Mangapee territory 12 weeks before the outbreak. The genomes from the squirrel and the mangabee were identical. They found, you ready for this? 1 video record of consumption of the same squirrel species in 2015. In addition, they identified 2 fecal samples containing the DNA of the fire-footed rope squirrel. I guess it was eaten by a mangabee, and then they've got the DNA in the poo. And so one of these samples was also the first positive for the virus in the mangapee group. This represents an exceptionally rare case of direct detection of an interspecies transmission event made possible only by long-term health monitoring. They conclude with, our findings strongly suggest rope squirrels were the source of the monkeypox virus or the Mpox virus outbreak in mangabees, since squirrels and non-human primates are hunted, traded, and consumed by humans in West and Central Africa. Exposure to these animals is likely responsible for at least a fraction of human Mpox outbreaks. And we got a cute little picture of a fire-footed rope squirrel.
So is this paper been accepted, or?
So right now, this paper is a preprint, and we're actually getting this news piece from Nature that goes through the.
Okay, so it's under review.
Under review, yeah.
Okay.
Okay. Now I realize this. We talk a little about pertussis on This Week in Virology. Pertussis is actually it's a bacteria, so it may not be a virus, but it makes you sick. And so I guess we're squeezing it into our clinical update. But I thought this was important to bring to people's attention because we're seeing a significant issue here. The U.S. has reported 6,600 cases of whooping cough, pertussis, in the first 3 months of 2025, more than 4 times the number at the same point last year, 25 times as many had been reported at the same point in 2023. If the current trend continues, the country will be on course for the highest number of infections since vaccination was introduced in 1948. There was a nice article at NBC News that I thought did a good job of capturing the human suffering, and so I just wanted to share a bit about this because, we always say people don't remember what you say, but they remember how you made them feel. And I think if we can connect this feeling with pertussis, this vaccine-preventable illness, we might move the needle. And here, let me read. Kate and Greg Moore weren't thinking whooping cough when their son, 13-year-old Joe, started having coughing fits in early March. Joe probably just had a late winter virus, the Bloomingfield Hills, Michigan couple figured. Maybe it was spring allergies. Other than the coughing, he seemed fine. Cough medicine didn't touch Joe's brutal and increasingly violent coughing jags, sometimes every 5 to 10 minutes for hours at a time. It was a very violent cough. I just had to pause what I was doing and wait until I was done coughing, Joe said. Sometimes it felt like I'd throw up. It was difficult to watch Joe's body convulse uncontrollably, said his mother, Kate. Nothing seemed to be working, she said. It just seemed really aggressive. He'd double over. Tests revealed that Joe had pertussis, a bacterial infection. It's also called whooping cough because of the sound some kids make during the coughing fits that Joe experienced. So really seeing a lot of suffering here.
And these are mostly people who are not vaccinated, right?
It's really the issue. This is a vaccine-preventable illness, And again, as we've talked about, vaccine won't necessarily protect you from getting infected, but they'll protect you from the disease, from the severity of disease. And we are seeing numbers rise. So, All right. Well, measles, and this goes right to your pessimism, I hate to say, Vincent. CDC cancels measles help for Texas schools amid staff layoffs. Normally the CDC jumps in, they help, they assess ventilation and things like that in the schools, but this is being canceled. The staff that was involved in helping the schools and monitoring the ventilation, they were called back. And some of the things they point out, and I think we just realized this is reality, is a lot of times the schools will have ordered these proper filters that need to go in so that the air is clean, so your kids, are actually getting HEPA filtered air and not necessarily breathing in those viruses from everyone else. But a lot of times those filters will stay in the boxes, and then the CDC shows up, they get out of the boxes, they get installed, we see improvements, but this is not happening. So let's get everyone updated here. So start off with the total US. We are up to 800 cases. Now, about a third of those, a little less than a third, are under 5. Over a third are in that 5 to 19. And actually the other third are basically in 20 plus and up. And 96% of this are unvaccinated or not known to be vaccinated. So this really continues to be an issue. And 11%, so 85 of those 800 have ended up in the hospital. So this is not just...
Go ahead. Sorry.
No, I was going to say this is not for quarantine. These are people who are sick, people struggling to breathe, and in some cases, not surviving.
I understand that epidemiological tracing has been limited because of staff, because people have been fired, and there was a vaccine push in Dallas. They had to cancel because they didn't have enough people to do it. They were going to do emergency vaccinations. So, this is a tragedy on all sides.
Yeah, this did not need to happen, does not need to happen, because it's ongoing, and the epicenter still is in Texas. We get updates on Tuesday and Friday. Texas, 624 cases since January, another 27 since our last update. And most of it is clustered in that western part of Texas, right where it borders with New Mexico.
This is happening because one person does not believe in infectious diseases.
It's really it's amazing what one person can do.
I would never have believed it if I didn't see it now. One person can do this, and everybody else understands the nature of infectious diseases, the importance of vaccination, and one person is thwarting all of this.
Yeah. So we'll leave in a lot of links for vaccinations, all the myths, all the safety, all the stuff there. So we'll continue to do as much as we can to keep this on everyone's radar. Things are going in the right direction with flu. Almost the entire country is in the green, low to minimal, except what is that orange state up there in the Northeast? You recognize that state, Vincent?
Yes, it's New York State.
That's right.
We have high, right? Yeah, we have high activity.
It's still, it's an outlier. I think this is a little bit of a blip, and then we're going to come on down.
New York State is a very populous state, and in particular New York City, right? It's very crowded. So,
and also last week we had a school break, so we actually went from this moderate low. We went up, back into sort of the lower edge of high. I think it's going to come back down.
So here's something for you. Today I get on the train, and it's full of mothers and their daughters. So it's apparently bring your daughter to work today, right? So dozens of kids are in there without masks. This is how transmission occurs.
No, kids don't transmit things, Vincent.
So I wore my mask, as I always do. But, you don't think about these isolated ways that people live, and that's it.
Yeah. I mean, it's great to have that mask in your pocket. You just get in a situation like that, and suddenly you're like really glad you can whip that mask on. And, nobody likes to be sick. So.
Today, actually, the air quality in the region is poor because there are these forest fires in southern Jersey.
Yeah, pretty significant fires down there. Yeah.
Yeah. And so you can smell it, and they say wear a mask if you go outside because it's bad for your lungs to inhale the particles. Yep.
All right, moving into RSV, and actually we are coming out of the RSV season. Levels are low, but we did get a A little bit of an update, actually. So I'm going to start with the headline, RSV vaccines, right? So trial shows waning efficacy of RSV vaccine across 3 seasons in older adults. A study of the single-dose respiratory syncytial virus RSV vaccine in older adults shows that vaccine efficacy waned across 3 RSV seasons, but suggests a booster vaccination 1 year after initial vaccination did little to provide additional efficacy. So a little surprise there. So let's go through the data. So we've got this article, efficacy, safety, and immunogenicity of the AS01E adjuvanted respiratory syncytial virus prefusion F protein vaccine in older adults over 3 respiratory syncytial virus seasons, a multi-center randomized observer-blinded placebo-controlled phase 3 trial published in the Lancet Respiratory Medicine, right? So these are the results from a randomized observer-blind placebo-controlled phase 3 trial of Arexvy by GSK with participants aged 60 years or older in 275 centers across 17 countries, Africa, Asia, Oceania, Europe, and North America. Participants were randomly assigned 1-to-1 to either receive the vaccine or placebo before RSV season 1. RSV, before season, and then you end up with a certain group who got it the first season, and they get a second dose or placebo. And we're going to go for it, and we're going to look at the primary objective, which is going to be efficacy against first occurrence of RSV lower respiratory tract disease over 1 RSV season. Okay. So efficacy analysis included 12,468 RSV pre-F3 recipients, we'll say vaccinated recipients, 12,498 placebo recipients, cumulative efficacy over 3 seasons. And I'm going to go through all the data, but let's actually just look at kind of what happened here. So I'm going to go to the figures. They've got some great figures, and we'll do it there. So we'll start off with figure 2. And so we're going to see the single dose pre-season 1, and then we'll talk about what about folks that get that extra dose. So season 1 was great, right? 82.6% efficacy. We're really impressed. Season 2, it drops to 56. Season 3, it drops to 48. So we're starting to see it come down. But really wide confidence intervals, right, Vincent? I mean, these are huge confidence intervals.
Huge, yeah.
And that's going to present a challenge when they go ahead and they say, well, what about, dose, 1 pre-season 1, plus you're going to get that revaccination. And then when you get into season 2, you're comparing a 56.1 without, 55.9 with that boost, we'll call it. And then you get to season 3. With the boost, you're getting 68.4. Without the boost, you've dropped to 48. But these very big overlapping confidence intervals.
Yes.
Right? So it's sort of interesting. Like initially you walk away like, didn't really help to get that extra dose. What's going on? Well, I think they may not have enough numbers. They may not, really, you've got confidence intervals going from 20% to 90. I mean, pretty hard to show that, you're going to end up with something outside of that.
Yeah, this is because, population is different. Everybody's different. So you're going to get a wide range of values in these kinds of studies, right?
Yeah, but it is nice if you look at one of the figure 1, I guess I'll say, you really see a nice separation between placebo and RSV. Yeah. You see a really nice separation between RSV and placebo with the revaccination as well. So it looks like you're continuing to get some level of protection, 50% or greater, in that 3rd year. It's just not clear that we have enough data, and we may need a lot of people call real world, basically post-marketing observation to see what's kind of happening as we go forward, because we're still trying to figure out when's the next time to get another dose of this vaccine. And COVID update, really moving in the right direction here all across. And I will sort of jump forward to that wonderful multicolored wastewater trend. And you can see we are solidly into the low area and on a nice downward trend, really looking like where we were about a year ago.
And it goes to this low level. It never goes away completely, but it goes
Yeah,
to a low
sometimes it
level
gets
and stays there.
just to the edge of the very low, which I think we're almost at. So I'm hoping we get like a few weeks, maybe a month or so reprieve, and then,
Well, last year it started up again, right, in May, June.
and it
But
was
that's
really
weird.
it's
That's
about
weird for a
May.
respiratory virus. So maybe it's going to lose its weirdness this year. We'll see.
I would hope, I'd love to have, just one peak, so instead of
Yes,
these
in
two.
the fall, winter, yeah.
Yeah, so start acting like a normal respiratory pathogen, please, if
Well, I think it's still close to where it originated, 2020, right? 2019, 2020. It's not that long ago. And maybe it will take more time for it to settle into this seasonality. We just have to look.
Yeah, it's
We'll
only
be here.
5 years. So yeah, we're learning, as this
Yeah.
happens. So all right, well, we're going to move ahead to COVID early viral phase. And I wanted to start off with, so we talk about, someone gets acute COVID. The recommendation number one is Paxlovid. So I wanted to talk a little bit about Pope Francis, because what did Pope Francis die of, right? So recently, about 2 months ago, Pope Francis got multilobar, people call double pneumonia, was quite ill, was in the hospital, survived that, the acute phase of that. But one of the things we've talked about quite often is that for the few months after an acute respiratory infection, particularly those that end up requiring hospital support to get through it, there's a significant post-infection increased risk of major cardiovascular events, right? Heart attacks and strokes. And so Pope Francis, he made it through that hospitalization. He got out there. He drove around in the Pope Mobile for Easter. But then, as we find out, he died. There was a stroke. There was heart failure. So really, a lot of us have seen this quite often before. A man of advanced age ends up with pneumonia, gets out of the hospital, but then just doesn't last much longer. And unfortunately, that's what we saw here. So one of the interesting questions with COVID is there something we can do about that? If we jump in that first week with an antiviral, and in this case, Paxlovid, can we reduce your risk of getting a stroke or dying in that 3 months post-diagnosis is what we're going to look at here. Because a lot of people are like, I'm not sure if I need that Paxlovid. I don't feel that bad. I probably won't end up in the hospital. But, I think one of the things that frightens a lot of us is, boy, I certainly don't want to have a stroke. And is there any way I can reduce my risk of having a stroke in the 3 months after this acute COVID infection? So here we have the article, long-term stroke, really not that long-term, but long-term stroke and mortality risk reduction associated with acute phase Paxlovid use in mild to moderate COVID-19, published in the Journal of Medical Virology. So here we have a retrospective cohort study where they investigated whether Paxlovid, nirmatrelvir, ritonavir, used during the acute phase of mild to moderate COVID-19 reduces the risk of ischemic or hemorrhagic stroke occurring more than 3 months post-diagnosis. So they use this TriNetX electronic health records. They're looking at 118 million patients in the United States, a very robust study. Looking at adults aged 18 years or older, probably could have looked at older and sort of narrowed this down, but looking at those with a confirmed COVID-19 diagnosis between 2022 and 2023. And they're going to look at folks that got Paxlovid within 5 days of diagnosis, and then the folks who did not get Paxlovid. Among 181,992 matched pairs, Paxlovid use was associated with a significantly reduced risk of ischemic and hemorrhagic stroke. It was about a 15% reduction. And we're also seeing all-cause mortality reduced by 32% during this long COVID period. So they're defining this as that 3 months or 90 days post-diagnosis. They went ahead and they said, well, what about age? What about sex? What about, carrying too much weight, hypertension, diabetes, hyperlipidemia, vaccination status or not? All the way across the board, consistent protective events. So, you're getting this 15% reduction in your chance of having a stroke. You're getting this 32% reduction of death. And this is in that 90 days, those 3 months after the acute COVID. So pretty compelling for, I think, a lot of people who, they're not that worried. I mean, for me, I'm like, I might die one day, but I certainly don't want to have a stroke.
It's too bad there isn't a similar treatment for pneumonia, right? Bacterial pneumonia.
It is tough. I think, and this is one of the sooner we can jump in with the antibiotics, the more impact we think we have on this. But yeah, we certainly see this post-hospitalization increase in major cardiovascular events in bacterial pneumonia as well. Remdesivir, molnupiravir, convalescent plasma. Early inflammatory phase, that's at week 2, potentially the bad phase. That's when we think about steroids, anticoagulation, pulmonary support, maybe remdesivir, or immune modulation. And I'm going to wrap us up here with COVID, late phase, past long COVID. We'll leave in a bunch of links as we do, but I wanted to talk about the article, The Effect of COVID-19 Vaccination on the Risk of Persistent Post-COVID-19 Condition, cohort study, the results of a population-based cohort study in Stockholm, Sweden, to investigate the effect of COVID-19 vaccination on the risk of developing persistent post-COVID-19 condition in individuals surviving the first year after a SARS-CoV-2 infection. This is something we've repeatedly shared data on, but here they're looking at 331,042 individuals. And let's go through the data. So you've got your unvaccinated as your reference. 1 dose of vaccine, you're seeing a 19% reduction. 2 doses, you're seeing a 58% reduction. And that 3rd dose is giving you a 63% reduction in your chance of getting long COVID. And they break it down with pre-Omicron, Omicron, are you female, are you male? They use 65 as a cutoff. And you're seeing consistent. And then even, I thought this was really interesting. If you look at no previous infection and people who've gotten infected before, right? Because people are like, I was infected before, there should be this protection there. In folks that got 2 or 3 doses after a verified previous infection, you're seeing a 60 and a 65% reduction in your risk of long COVID.
Are they all getting the same vaccine, or is it a mix of different vaccines? Do you know?
So it's a mix of different vaccines, but mix of different vaccines. But it's really interesting, right? Because a lot of people are like bitter, like why did they encourage me to get vaccinated if I already had an infection? I was already fine. Well, a lot of people are not already fine. I think many, many more people are suffering from post-COVID conditions than died. And so seeing this, say, 60% reduction in post-COVID conditions, heart failure, strokes, chronic fatigue type syndrome, all the rest, that's huge. This is really a strong argument for encouraging people to get vaccinated, even if they already had previous infection, even if they survived that first infection.
And what people should understand is that at the beginning of a new virus circulating, right, a pandemic, you don't know a lot of things. So you exercise the utmost caution, you get vaccinated. And so why did they vaccinate me? Well, we thought it was the best thing to do. And now when we finally did these studies, it is.
We realized, we confirmed that it was the best thing to do. Yeah. It's all that bliss of ignorance. It's all that joy. They just can't contain the joy of ignorance. All right, Orchestra, Delphi Consensus, Diagnostic and Therapeutic Management of Post-COVID-19 Condition in Vulnerable Populations, recently published in CMI. And so this is a consensus document. They end up with 11 statements, 6 on features, risk factors of post-COVID conditions in clinically vulnerable populations, 2 on diagnosis management, 3 on prevention. Couple highlights: chronic fatigue was identified as the most frequent presentation of post-COVID conditions. They suggest that a different case definition of post-COVID condition is required for people with rheumatic diseases. Because a lot of times autoimmune disorders, post-COVID conditions can kind of be an overlap here. So, looking at people like that. So just sort of throw that out in a link for people. And there was a recent article in Spectrum News about the Mount Sinai Long COVID Clinic. So a little highlight for the Mount Sinai. The medical director of this clinic is Zijian Chen, MD, an endocrinologist and associate professor at Mount Sinai. The individuals they interview for this, or the individual they interview for this article, is David Petrino, with whom I've spoken. He's a physical therapist with a PhD in neuroscience. He's a full professor at Mount Sinai. David Petrino he's become the face of this clinic with a number of media appearances and publications. And I was thinking, this whole trust in science issue from last week, maybe we trust physical therapists more than MDs, or what about neuroscientists? So I looked at that chart from last week, right? Because we've got, Dr. Chen is the MD, but then we've got David Petrino, who's a licensed physical therapist. And I looked through the thing, and actually, neuroscientists are quite well trusted.
Yes,
you see that?
They are. Yes.
Yeah, so I just wanted to point that out. But the article highlights the $10 million Center for Post-COVID at Mount Sinai. This is part of the Cohen Center for Recovery from Complex Chronic Illnesses, of which David Petrino is the Nash family director. This center began as a specialized clinic for long COVID treatments, but it's expanded. They now treat a range of conditions, including ME/CFS, tick-borne, vector-borne illnesses, things like Lyme. People have issues after Lyme, connective tissue disorders. Now, this clinic is not funded by any federal funding, not supported by any federal funding, so safe for now. They provide clinical care and access to research studies, and I'll leave in some links in case people want to explore this clinic. I've had several patients go there. And then I'm going to wrap us up. If you want to reach out to your representatives, I'm going to leave in a link to house.gov/representative/find your representative. So you can let them know what you would really like, what you want our government to be doing for you and the world. Because as we've been saying for 5+ years, no one is safe until everyone is safe. That's how we make America great, by making the world great. I want everyone to pause the recording right here, go to parasiteswithoutborders.com, click donate. Every bit counts. Thank you so much for the people that have stepped up this last week. We're now doing our Floating Doctors fundraiser, where February, March, and April, we're going to double your donations. We're going to get to that maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Michael writes, "Dear Dan," he calls you Dan. I don't know if you know, Michael. I am a slightly less energetic ID physician than yourself. I'm amazed at all you accomplish as an ID clinician and communicator. Why do you think they have not tried posaconazole antifungal prophylaxis in The Last of Us?
Yeah, so why not posaconazole or voriconazole? So maybe people need a little background. I don't know if all our listeners are the Last of Us aficionados or watchers, but so The Last of Us is this fantastic TV show that I will endorse, which starts off with cordyceps, which is the zombie ant fungus. There's a form of cordyceps that is mutated and is now infecting human beings and turning us into zombies. And it's really interesting to think about how it works in the ants. So they initially get exposed to the spores, and then the spores then germinate, and then they end up with fungi, and the fungi develops close to the brain and actually activates certain neurotransmitters and gets the ants to engage in different behavior than they would normally. There's a fungus that infects spiders that gets this recluse type of spider to come out into the open. Well, in the movie, the people are getting infected. And actually, I got to say, Vincent, I've watched a lot of zombie movies. These zombies are really fast. In one of the most recent episodes, I don't know if it's much of a spoiler, but the horses are having trouble outrunning zombies. And horses are fast, right? So suddenly but apparently even in the ants, the fungi can actually get involved, get into the legs, and can actually secrete things that are sort of, stimulants. So maybe that's who knows what's going on. But yeah, so would it make sense? Now, unfortunately, a lot of the time, the interaction between these zombified human beings and the regular humans, it involves a lot of violence and pretty significant biting. Now, would the posaconazole allow you to get a bite without getting infected? This is some good ideas. They should be, thinking about them. I mean, why not? People are taking ivermectin and other things. I think in the time of the zombies, I'm sure there would be a black market for posaconazole, voriconazole. Yeah.
They're just going to take ivermectin.
So good idea, Michael. Got to test it out.
Carol writes, my son and daughter-in-law are expecting their first child in October. What vaccine should my daughter-in-law get during her pregnancy and when?
Oh, so this is great. I'm glad you're asking this question. So, it's going to have this conversation, with your daughter-in-law's OBGYN, but maybe you kind of go in with the knowledge ahead of time. So let's think about what's recommended during that last trimester. So during the last trimester, thinking about, this young lady going into October, right? So you're going to want to think of how does she protect herself? During that fall as well as into the winter. How does she protect the newborn? So some of the things that we've talked about. So COVID, we'll start with the COVID vaccine. Getting that COVID about 3 months before, so right into the beginning of that third trimester, that's going to protect her, increased risk, also going to passively protect the baby during the first 6 months. We also recommend the flu shot. Don't forget the flu shot. We also have an RSV shot to do during that period of time. We also have the Tdap, so the tetanus, diphtheria, acellular pertussis. And then just the little thing is once the baby is born, we've now talked about doing not only the RSV shot for mom, but also doing the nirsevimab, the passive antibody for the newborn baby.
And of course, Hep B for the baby also, right?
Yes, yeah. There'll be all those childhood vaccines, yeah.
Philip writes, Colombia is seeing a wave of yellow fever. I had the vaccine in 91 at 33 years of age. I repeated it before I turned 67. I had no adverse effects. The nurse practitioner said my risk was lower as I had been vaccinated before. I'm happy with the NP at my travel clinic. My wife is Colombian, and we plan to spend time in Colombia in retirement as well as countries that might require vaccination. My wife is 71, good health. Her prior vaccination status is unknown. Like I said, I have a good NP. I told her about TWiV, and she was impressed. My conversation with the NP involved effectiveness of the 91 shot versus odds of getting infected. Was it riskier to get the shot or the infection? What would your concerns be with giving a 71-year-old her first yellow fever vaccination? How about chikungunya vaccine?
Yeah, so these are some great questions here. So first, let's start off with what we know about the yellow fever vaccine. So it used to be you got the yellow fever vaccine, and then every 10 years you got a yellow fever vaccine booster. The current thinking is one shot is adequate for a lifetime protection. So it's not clear that you need another shot. So, but it's also, as far as side effects, we'll get into in a moment. If you tolerated the first one, you're fine. Second shot, you're going to be fine. Here's where we get into trouble. We have seen, and it's about 1 in 100,000 folks will get a side effect if they get that first yellow fever vaccine over the age of 65. But you can kind of look at like, well, how healthy is the 71-year-old that we're talking about? But no, we have seen in individuals about a 1 in 100,000 will actually end up having pretty significant side effects from this replication competent yellow fever vaccine. The other, you ask about the chikungunya vaccine. Yeah, you want to look at that. This is now, we just got recent hot off the press recommendations for travelers going to areas where there's ongoing chikungunya or active chikungunya cases. I think Reunion is actually having a big outbreak at the moment. So yeah, chikungunya is now on the list of recommended for travelers that are heading to areas with significant chikungunya activity.
Carson writes, I tested positive for COVID by rat on April 2nd, same day as symptom onset. By 4/8, I was negative. I know, I'm not supposed to retest, but I wanted to know. Since then, I've had a mild occasional cough. However, since 4/20, my cough has gotten progressively worse. Note, I did not partake in any 4/20 related activities. At first, I thought it might just be a residual effect of COVID or maybe COVID rebound. I blamed my progressively worsening congestion and failure on the cough kicking up mucus and make it difficult to sleep. But now, 4/23, I'm starting to feel pretty sniffly, unrelated to the cough, and I'm wondering if I'm just sick again. I did test again for COVID. It was negative. Could it be COVID rebound 3 weeks out, or did I get another cold virus? And a side question, at what point is it not overdramatic to go to my doctor about this cough? And I did not take Paxlovid.
Okay. So I'm trying to figure out, you didn't take Paxlovid, but I don't have any age or risk factor. So I don't know about the criteria there. This does not sound like any kind of rebound. So remember thinking about, what we have here. So we have the acute viral week. Then we have that inflammatory second week. Now, during the third week, some people, that's when we see the secondary bacterial infections, right? And that's really part of COVID. It can be part of measles, right? You have an initial viral phase. You end up with a number of changes in the airways, a number of changes in your immune system, increased vulnerability to getting something down the road. If you've got ongoing cough, you're not feeling well, I don't think it's overly dramatic to go to the doctor. Let them listen to your lungs, let them look at your throat, let them try to figure out what's going on. And hopefully they're going to be wise in determining whether, what exactly would be the best thing for you. Never over dramatic to go check in with a physician.
And Lauren writes, I would love listening to your podcast. I have a question about chickenpox and shingles vaccine. I had a very mild case of chickenpox as an infant, developing just a few spots when my sister had a full-fledged case, had the vaccine in my mid-20s, and then had a lab-confirmed breakthrough case of chickenpox in 2020 when I was 39, despite rarely leaving the house during the pandemic. My PCP can't decide if I'm at increased or reduced risk for shingles given my recent chickenpox infection. What do you think? Does an adult breakthrough case of chickenpox increase or decrease the risk of getting shingles? If it increases risk, should someone who got chickenpox as an adult get their shingle vaccine early?
Yeah, so this is a great scenario. So, it's something has me a little concerned. So here you get chickenpox. It sounds like it was a mild case initially when your sister had this full-fledged. Then you get the vaccine, right? So we're thinking at this point, you're protected, your risk is very low. But then you actually go ahead and you get a full-fledged lab-confirmed breakthrough, post-vaccination, post-infection case of chickenpox. There's something up with your immune system that made you susceptible. That is not a common, that's a rare occurrence. I think I would say, just putting this all together, you're probably, with an N of 1 here, you're probably at an increased risk of shingles. So then this really becomes a good question. Do we wait to 50 before you go ahead? That is the recommendation. Or do you start thinking about getting that earlier? So we don't know. This is one of those, limited data zones. But I think you're raising a lot of really good questions. Certainly the day you turn 50, go ahead and get your shingles vaccine if you hadn't gotten it any earlier.
So she was 39 in 2020. So now she's 44, right, Daniel?
Yeah, so we're almost there, right? Or she'll be turning 44 this year. So she's pretty close.
Yeah. That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.